Today we are looking at intra-articular joint injections. So if you have ever been given an injection into your joint, I hope you can do some flashbacks. So we shall need to make sure that we don't have any excess fluid within our joint, because this is another volume of substance that we're going to add in the knee. So if you already have excess and you're having another volume being added, this is increasing in volume still and increasing in pressure. So this will cause more pain to the patient. Then after that, we shall look for the surface markings which will guide us within our joint. And in this case, we are using the knee. So for the knee, we usually use the inferior pole of the patella, the lateral aspect of the tibial plateau with the joint line and the patellar ligament. So just lateral to the patellar ligament is where we have a depression, and it's where you are seeing being marked. Just nice to know, why would someone prefer this intra-articular steroid injection over the usual NSAIDs? So remember that when we have cellular damage, these plasma membrane phospholipids are going to be converted to form arachidonic acid, and arachidonic acid will be converted to these prostaglandins and those other chemical mediators by the different enzymes. And remember, where these steroids work, they will inhibit phospholipase A2, which converts those phospholipids to arachidonic acid, and yet these NSAIDs, for them, they inhibit the cyclooxygenases, which convert the arachidonic acid to the prostaglandins and those other chemical mediators. So we will have a higher potency with steroids compared to the NSAIDs. And also, being that you have given this injection locally where the inflammation is occurring, so you'll have a faster onset of action compared to the NSAIDs, which will take systemically through the mouth, then to the gut, to the liver, to the circulation, and then back to the knee. So that will be a longer time. Then also remember that these joint pains and those other intra-articular pathologies, sometimes they are chronic. So someone may need to take NSAIDs for some good time. And you know there are disadvantages with chronic use. Those NSAIDs. So I would opt for an intra-articular local injection, which is not going to go systemic to cause those side effects. Though they also have shortcomings. For example, sometimes they can cause erosion of those joint surfaces, the cartilages and those membranes. Sometimes they can cause local irritations. And also, there is a little bit of limited duration. But of recent, there have been improvement in the technology, and there have been introduction of those depots. So you can give an injection and it can last for some few weeks. So back to the injection, remember we have already identified the site of entry using our anatomical landmarks. Today we are using the knee, and these anatomical landmarks define each and every joint. So after getting to know where our introduction of the injection will be, we shall proceed and clean our knee aseptically in all those aseptic techniques. Remember, we are moving from the external environment into the knee cavity, so we don't want to introduce any microbes into the knee, because this is an aseptic procedure. So after that, we shall infiltrate our skin and the deep structures with local anesthetic, and this will help to reduce a bit of pain. Yes, of course, we shall introduce our needle into the skin and to the deeper structures as we continue to aspirate to see that we are not in the vessel, because our aim is to infiltrate in the surrounding structures other than the vessels. So we shall administer it as we move to anesthetize the surrounding structures as well. Then after that, we shall give it a bit of time, around a few seconds to a minute. Then we shall get the syringe that contains the steroid drug. Of course, open the cap and introduce the needle into the knee. Our aim is to get the knee cavity. So we shall maintain the needle in a horizontal plane, but as we are entering, our direction will be a posteromedial direction. After reaching the cavity, of course, we shall aspirate and see whether we are not in the vessel or not. After seeing that we are not in the vessel, we shall advance the drug and remove the syringe, or remove the needle. After that, we shall instruct the patient to perform a few movements in the knee, that is extension and flexion, to make sure that if assisted in the distribution of this drug. Then after, we shall inspect for any bleeding at the site of the injection. If you have no bleeding, of course, we shall put a bit of pressure with cotton, and that will be it.